Hi, everyone. Angela Love-Zaranka from Lactation Education Resources. Welcome today.
Sekeita Lewis-Johnson, and I second that welcome.
So we know that you all are probably going to take the exam in about 30 days. And so you're thinking about it a lot and you are wanting to make sure that you're ready because you've invested so much time and resources into this process. And so we are here to try to provide you with a few little hints that you can use and or just a brief overview on exam prep and getting ready for it and how should you focus, how you should focus or how you may want to focus these last 30 days. So before we get started, just a little bit of housekeeping. How to ask questions. So if you will notice here, if you're participating on a laptop or on a desktop, you will notice this nice blue arrow, which is pointing to the questions box. There isn't a chat box in GoToWebinar, but there is a questions box. So feel free to test it out now. Type in there where you are participating today and let us know where you are in the world today. The second thing, though, if you are participating on a mobile device, then you want to take a look for the green question mark, which is at the bottom of the interface. And so take a look there and feel free to also type in, let us know where you are participating and test it out, and feel free to type any questions in there. We actually have Julie from our amazing customer support team on the call today. Julie is also an IBCLC and has taken the exam more recently than I have. And she is there to answer any questions that you may have. Jill is our tech magician, and she is also on the call. So if you have any tech issues, please type them into the questions box and we will take care of them. So just a couple of ground rules. Please do not photograph or record the information with a camera, phone, or other equipment. We are recording it and you will be able to review this session as many times as necessary. Now, a few of the questions will be answered during the session by Julie, as she is an IBCLC and recently sat the exam. So they will flag other questions for us, which may be asked by several of you, and Sekeita and I will answer them at the end of the session, even if it means the session is going to go a little bit longer than 90 minutes. So just be ready for that. Okay, so we are going to first start with medications. And so, Sekeita, I will turn it over to you. Sekeita.
Thank you, Angela. So, Angela alluded that she hasn't taken the exam in a minute, but I took it in, I believe, 2018. So fairly recent. That was my second time taking the exam. And so thank goodness we only have to take the exam once now. So I'm going to bid you all a best wishes. The other thing I'm going to say before I get started, our first topic is medications. And I want to acknowledge that in this space, we have folks that have never been in healthcare in an institutional way. And we have those who have been in healthcare for possibly years. And so as it relates to medications, this is for really a lactation focused discussion. And so I wanted to just say that before we get into any of the nitty gritty. The other thing I want to say is just relax. We have a handout. The medications section is a handout that we provide for you. So really just kind of take a breath, take a moment to kind of listen to this information because you'll have the handouts. All right, so the first thing I'm going to talk about is our medication, the key points that is necessary for you to remember as it relates to, again, lactation specific, compatibility of milk with breastfeeding or human milk feeding or chest feeding, all right? So it's important to remember that the amount of drugs that is excreted into milk has many factors. It depends on many factors. So let's take a look at some of those. The milk to plasma ratio is used to evaluate the concentration of the medication in the plasma compartment as compared with the milk. And when I say plasma, I mean the plasma of the birthing parent or mother. So that's what that comparison is. Next, we have the relative infant dose. Now, this is an important clinical factor to determine safety. Now, notice I said the first one was just to determine if the milk enters, if the medication enters into the milk. This is really a safety parameter. Or when we talk about safety, we also use the word compatible. So it's usually expressed as a percentage of the maternal or lactating person's dose. And according to HEL's medication in mother's milk, a relative infant dose that is less than 10% is considered relatively safe for a full-term newborn infant. And I'm stressing the full-term newborn infant because we know that in the special populations, NICU populations, or anyone that has any preterm factors, it would be a little different. So what I'm saying, a relative infant dose greater than 10% for a full-term infant should be a reason to pause and should be a reason for further assessment. Other things we look at is called oral bioavailability, and that determines the plasma levels and overall risk to an infant. And so it really refers to the ability of the drug to reach circulation after it's ingested. Drugs with low oral bioavailability are generally poorly absorbed in our GI tract and usually are destroyed and are taken up by the liver prior to even entering into the circulatory system. So another thing to keep in mind is medications enter the milk compartment only if it's entered into the lactating person's blood or mother's blood, all right? Also true during the initial colostral phase is that the transfer of medications into milk is usually higher. And the total dose though, so it's usually higher, and there's a rationale for that, and that's because the compartments and the milk globules, they're all spaced out. But as our bodies begin to get into the other phases of lactation, those as the ducts proliferate, the junctions close, and so milk does not transfer as easily into medications don't transfer as easily into the milk. But so remember that the transfer of medications into milk is high. However, the total dose transferred to the infant is lower because, again, infants are not getting tons and tons and tons of colostrum. So I really hope that makes sense. But if it doesn't, you can ask questions in the chat. All right. Keeping on with the additional medication key points. Again, most medications enter milk at clinically insignificant levels. To determine the levels in milk, sometimes we use the lactation risk category in conjunction with the relative infant dose. Now, I'm stating that because in some of the next slides, I will have the lactation risk category. The lactation risk category was developed by HEL, and pretty much it's L1 is the safest, L2 is safe, L3 is probably compatible, L4 is, I'm forgetting right now, it's at the top of my head, potentially hazardous, and then L5 is just completely hazardous, it's a no. So I said all those things because when I show you these upcoming slides, you're going to be like, whoa, what is this L1? You don't have to remember whether a medication is L1, L2, L3. It is really there for you to kind of conceptualize how medications are safe, can be compatible. I'm going to try to use the word compatible most times because all situations are a little, can be individualized. But so that's why they're in the chart. So don't start to remember the next charts. I want to give you that caveat. So you also want to be cautious of high vitamin doses. Another key point is to avoid high doses of sedative medications, opioids, radioactive agents, anti-cancer drugs, which is also chemotherapy, and high doses of iodine. So in the first few slides, I tried to explain how medications get into milk. Now, some other key components to think about is that drugs can enter into milk. I said that if they're in the maternal person's plasma, right? If they have high concentrations in the maternal plasma, if they have low molecular weight, low protein binding, and pass easily into the brain. So when we talk about low molecular weight, anything less than 1,800 Daltons, that's what we talk about. So if you look inside of any, for instance, Hale's medication in milk, you'll see that all of these things are listed right beneath the drug in this little table format, so that you would be able to kind of discern as a clinician, you know what is the brief synopsis of this medication. However, one of the things that I love about that medications and mother's milk is that there are studies that are listed up under that table to kind of guide you and give you just a little bit more information in how you should proceed with caution based on that particular drugs. So in essence, you want to choose medications with short half-lives, high protein binding, low oral bioavailability, or high molecular weights. And again, you will have this in your handout. All right, antibiotics. All right, so antibiotics are commonly prescribed, and many providers and clients will often have questions about their compatibility with providing human milk. And the reason being is because, you know, sometimes antibiotics are not indicated right after birth, but sometimes people can develop certain infections that may require them to have antibiotics. So as a general rule, antibiotics are compatible with breastfeeding or providing human milk. There is a caveat. If you look at this chart, if we're looking at ciprofloxacin, is noted to be an L3, and because it's been associated with GI problems. Now, really, most antibiotics, the biggest concern, I should say, with taking antibiotics are that there are changes that occur to our gut flora and the development of resistance. So those are some of the key things that could potentially be, I guess I should say, a side effect of taking antibiotics. Now, one of the things to also note is that if you're not familiar with many of the drug names, it might be helpful to know, and this is not all, but it might be helpful to know that many antibiotics end in CIN or LIN, ampicillin. And this is true for, again, many, but not all. So don't go and say, I got that wrong because Sekeita told me if it ended in this, it was no. I said most. All right, antifungals. These drugs are used for fungal infections such as thrush or oral infections or other fungal infections. The infant and parent should both be treated simultaneously, but if you look at the drug categories, you see nystatin is relatively safe, compatible. And if you look at the other two, they're relatively safe and compatible. The thing with any antifungals is if, for instance, if an infant has thrush, the infant and parent should always be treated simultaneously, as the infection can pass back and forth easily. Topical antifungals such as nystatin are used to treat yeast, and sometimes they're used topical. They're considered safe as long as you're using just a minimal amount to apply so that the infant only gets a limited oral absorption, not a lot, okay? And let's see, I wanna make sure I'm not missing anything. clotrimazole has been associated with contact dermatitis and should be avoided if possible. However, it is listed as an L2. Analgesics. These are simply pain medications. And pain medications, we know that they are common after birth. This class of medications have various compounds that make some of them compatible with providing human milk and some of them not compatible. So take, for instance, Tylenol. So Tylenol is an L1, which is compatible. It's the safest, right? Right now, there's been some data that suggests some other things. However, if you combine the Tylenol with codeine, it then becomes potentially hazardous. Why? Because codeine is an L4, potentially hazardous, all right? Remember I said that an L4 classification indicates that a medication is possibly hazardous. And the rationale is that for this particular medication, and the reason why I'm going over this, because we used to use Tylenol 3 a lot for postpartum pain. But the rationale now, what we know now is that there are a few people with a genetic trait that makes them rapid metabolizers of codeine. And so the FDA, and there are numerous drug advisory groups that have said no codeine with lactation. So moving on to like Motrin, something like Motrin, that's a non-steroidal anti-inflammatory, and that's an L1, right? Again, various drug classifications, wide range in this area of analgesics. Aspirin is an L2, however, it's not safe to use if the infant is sick or has a fever because its association with Reye's syndrome. Morphine is usually given for someone who's had surgery. They birthed by surgery, and morphine or Dilaudid, they're L3s. Now I'm saying L3s because we said, okay, but that L3 is probably compatible, and that is if it's used for only a limited amount of time, it appears to be safe. But all narcotics should be used only for short frames and only as they are prescribed. Some of the concerns that can happen with some of these medications is sleepiness and poor feeding. And so those are things to watch out for if you have someone who's potentially been discharged home on some type of narcotic medication and the baby is just sleepy, won't wake up. That's something to consider. And so just keep that in mind, that the compatibility of the medications listed above are only if they are being used as prescribed. Anti-convulsants is seizure medication. This is here for the same reason. It's just to kind of give you an idea of the category and to give you an idea of how safe the medications are. I remember working as an L&D nurse long, well, it's been a minute, maybe about 9 years since I've actually been in practice. But I will say that there used to be magnesium is not safe. This person's on mag, they can't breastfeed. Well, now we look at this category and we see that magnesium sulfate is an L1. So it's always helpful to refer to resources when we're talking about different medications. Some Depakote is an L4, so that's a seizure medication that you take a pause on, and it warrants, like, let's really look at this because it could be potentially hazardous. The concerns with any anti-seizure medicines, the medicines that impact our central nervous system, is really the same concerns that could happen in a person taking it, would be sleepiness, irritability, and the infant could have also some poor feeding habits. Now, there are so many antidepressants on the market. These 3 antidepressants are the ones that appear to be compatible with providing human milk. We know that postpartum mood disorders are common. And on this spectrum of mood disorders, there are times and some conditions that require medical management or medication management. These medications are all listed as L2s, and they're listed as limited data, probably compatible. According to HELS medications and mother's milk, Zoloft seems to be the preferred. Keep in mind that there has been some controversy on the safety and compatibility profiles of antidepressants. However, it's important to remember the risk-benefit ratio. Some concerns to monitor for is sleepiness, poor feeding, low muscle tone, and agitation. And so I'm going to pause right here because I want to say, if you notice the last few slides, you've noticed that some of the concerns with some of the medications have been monitoring infants for sleepiness or poor feeding or agitation. So those are all things that are pretty typical of a lot of the medications that we consume. Antihypertensives. This question is always becoming more and more common, as we know that pregnant people are having comorbidities like no other, particularly with heart conditions. Cardiomyopathy is one of the leading causes right now of morbidity, mortality in the United States, right? So this exam is not just the United States. I know this is an international board of exam, but I do want to just state that if you look at the drugs and you look at the common names and you look at the categories, most antihypertensives can be compatible. However, they do require some extra wherewithal to look them up, to really know them. However, for the exam's sake, again, you want to monitor the infants for sleepiness, lethargy, pallor, or poor feeding. The other thing about antihypertensives, there are two medications that are listed below, and those are what we call diuretics. If you hear people say those are water pills, those are pills to get the excess fluid out of our bodies when the fluid is loaded up on us in third spacing and those things. So key things about those two drugs is that they do have the potential to reduce milk supply. And so diuretics, which is those last two at the bottom, you really want to really be really cognizant of making sure that providers, or we're in collaboration with the client so that they know, hey, we have to have a plan for this. Vaccines. Generally speaking, vaccines are safe while breastfeeding or lactation or chest feeding or providing human milk. However, yellow fever vaccination is not recommended. And when it comes to smallpox, I'm going to read an excerpt from Lawrence and Lawrence because some people get a little like, well, no, it's not recommended. Oh, yes, it is. And so I'm going to read verbatim. All right. And this is from a guide, Lawrence and Lawrence, Breastfeeding, a Guide for the Medical Profession, 8th edition. It's on page 402. And it says smallpox vaccination is inadvisable for the mother of an infant younger than 1 year of age, nursing or not. The personal contact, not the breastfeeding, causes the risk. Therefore, no advantage exists to weaning if vaccination is necessary. However, this vaccination is not given routinely and is rarely indicated. So that sums up the portion of medications. I hope that this will help you in your study endeavors to make sense. Again, try not to remember, but just try to know the information, meaning to be able to apply it to a question. Some questions are not just, is this drug an L1? It's usually given in the format to help you think about, like, what are the ramifications? So for instance, if I said, you know, this person is taking an antibiotic, their baby is blah, 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 blah. What might you be concerned about? You might be concerned about the gut, or you might be concerned about antibiotic resistance. And so that's the level that I'm hoping you come away with when it comes to the medications. But I'll be here to field any questions about anything that I said that may not have been so clear, but keep in mind you'll have that PDF handout about it. So Angela, jump on in.
Thank you so much, Sekeita. So I should have said this in the beginning, but just to kind of give you a little bit of a landscape as far as what we're going to cover today. So we are going to cover those topics that people have the most challenge with. Therefore, we started with medications. Now we're going to move on a little bit and we're going to talk about breastfeeding beyond the first month, because it seems that exam candidates do really well in those first few days of lactation. However, as time goes on, the exam scores tend to drop just a scotch. And so that's the reason why we are covering this. Also want to mention, thank you for all the questions that you have in the chat. Sekeita is going to go take a peek at them now. And indeed, this will be recorded and you will receive an email with the link to the recording. And so don't fret, you can watch this as many times as you need to. So also a little bit of background on me. I am both a private practice as well as a hospital-based IBCLC, and I've also provided peer support in lactation care for the past many years. I'll just say many, so more than one. So I want to now cover some topics which indeed some people may find challenging, which are breastfeeding beyond the first month. And so any sort of parental concerns, fertility, tandem nursing, and weaning. So when counseling clients with older nurslings, be mindful that the number of feedings and the time at the breast may fluctuate greatly. Babies might return to intense breastfeeding to adjust their parents' milk production as needed, which is sometimes referred to as growth spurts. They often occur around 2 to 3 weeks, 6 weeks, and 3 to 4 months. This coincidentally coincides with a shift in maternal hormones with the gradual transition of endocrine to autocrine control of milk production. Developmental milestones may increase night waking and nursing. These little ones seem to be too busy exploring the world during the day to spend time at the breast. They may miss something. Therefore, they may wake more frequently at night to receive the caloric intake they require and what they intrinsically know they need. Latch and position techniques are considerably more flexible after the first few months. Note in the picture here that the baby is further away from the breast than when a newborn. Unless the parent is uncomfortable, there's no reason to suggest changing the position or the latch. Breast and nipple pain are two challenges that some parents face while lactating. This is one portion of a 13-page algorithm developed by the University of North Carolina, located in the United States, for breast and nipple pain. It's a very valuable resource and a good review prior to the exam for how to identify many causes of breast and nipple pain. Now, mastitis. Mastitis is an infectious process in the breast that produces localized tenderness, redness, or discoloration of the skin and heat together with systemic reactions of fever and malaise. Prospective studies estimate the incidence to be between 3 and 20%. Depending on the definition and the length of follow-up postpartum, depending on the definition and the length of the follow-up postpartum. Technically, mastitis is an inflammation of the breast, which may or may not involve an infection. The problem can begin with engorgement, then non-infective mastitis, followed by infective mastitis, and to abscess if treatment is not promptly introduced. So symptoms could include a fever of 38.5 degrees centigrade or 101 degrees Fahrenheit, chills, headache, flu-like body symptoms and aches. Breast is painful and swollen. The chest area or breast area is red or hot or tender to the touch. You may note red blotches or streaks or what appears to be bruising or discoloration of the breast. So treatment for mastitis includes rest, continue to feed and or pump on the affected side, warm compresses, creative nursing positions, support compliance if antibiotics are prescribed, and to use analgesic or an anti-inflammatory for discomfort, fever, and swelling. So now note in this image, I intentionally chose this to try to help you to see the mastitis. it can be challenging to note overt inflammation or redness on someone with different skin tones than a white appearing person. Now, recurrent mastitis. So we have delayed or inadequate treatment of the initial disease and continued milk stasis. So Jimenez found that Staph aureus dominated the microbiome of mastitis sufferers. However, Staph aureus was found by other researchers in the milk of asymptomatic women. So in the case of recurrent mastitis, as I mentioned, the cause could include delayed or inadequate treatment of the initial disease and continued milk stasis. Diagnosis can be made with a culture of the milk and infant naropharynx or oropharynx swab. So now, I'm sure that if I took a pause at this moment and I asked questions about the new mastitis protocol, I'm sure there's like 500 questions in the chat about the new mastitis protocol. And so I just want to take a quick moment here to say that this exam was likely created, if not a year ago, possibly 2 years ago. And all of the items on the IBLCE exam, so now I'm going to wear a hat where I actually served on the IBLCE Board of Directors and on the Exam Development Committee. And so I know that because of translations and a variety of other reasons and other factors, that this exam was possibly written quite a while ago. Therefore, the questions about the new mastitis protocol, which was published just a few months ago, will likely not be on the exam. And there are several reasons for that, but not the least of which has to do with translations. And so the exam is written and then the exam is translated into 17 different languages. And the different translations are provided in the September exam. In the March or April exam, the exam is only provided in English. However, in the September exam, it is presented in a variety of languages. Therefore, it is important to note that there is a good possibility that the information about the new mastitis protocol will likely not be on this exam. So hopefully that has allayed some of the concerns. Now, if we talk about, and you'll see here why I have it in red, address the new protocol, a small percentage of breast infections develop into abscess. Kinley et al. Reported the incidence to be about 5 to 10%, whereas Amir reported about 3% of women with mastitis in her sample developed an abscess. One theory is that healthcare providers are more educated on the prevention of abscesses. Dr. Lawrence reports an increase in abscess rate when antibiotic treatment was delayed beyond 24 hours. Now, an abscess is a localized collection of pus that forms from an infection that has no opening for drainage. The indications for an abscess are the same as mastitis, although symptoms may be less severe in the abscess is isolated from the rest of the breast. This picture demonstrates an obvious abscess. Occasionally, an abscess can occur in the absence of any systemic symptoms. When antibiotic treatment has been delayed by 24 hours, that's usually when the abscess rate increases. So treatment is going to include, for small abscesses, which is less than 3 centimeters, the recommended first line of treatment is fine needle aspiration, single or repeated, preferably under ultrasound guidance. For abscesses greater than 3 centimeters, a percutaneous suction catheter can be placed for 3 to 7 days with oral antibiotic effective against penicillin-resistant staphylococci for 10 days. For larger abscesses, the healthcare provider will incise and drain the area. A drain is placed to promote drainage. The incision heals from the inside out, and it can take a week or two. The parent can continue to nurse on one or both breasts, depending on the location, associated pain, and medication. Okay, now we're going to skip over to pregnant and nursing. So pregnancy while nursing can occur. It's really helpful to explore the parent's feelings about the continuation of breastfeeding. Some parents will note nipple or breast discomfort. Some report the discomfort alerted them to the new pregnancy. Depending on the age and nursing relationship, some nurslings may be reluctant to wean. Now, mature milk will change back to colostrum around 4 to 5 months into the pregnancy, which may change the taste and the quantity of the milk. Oxytocin is released during nursing. However, the oxytocin is blocked by progesterone. There is no need to wean a nursing baby or child unless there is a true risk of preterm labor. There is limited data which shows an impact on the mother's nutritional status by continuing to nurse through pregnancy. Therefore, it is important that the parent is mindful of their diet. Some older babies or toddlers may stop nursing during the pregnancy and resume after the birth. Tandem nursing is the term to describe breastfeeding of 2 or more children who were not born at the same time or are of different ages. It occurs when a parent nurses through their pregnancy, or if the previous child weaned during the pregnancy may be interested in returning. It's important to explore the mother's feelings again about the tandem nursing. As one of the pioneers in the lactation field, Shelley Marmette once said, it takes the patience of Job to tandem nurse. If there is an issue with the infant's weight in the early days, it's important to ensure that the newborn is given priority at the chest or breast. Some parents will dedicate one breast to the newborn and the other to the toddler and switch during the day. Note here the way that the older sibling has her arm around her new brother. Granted, it may be so that everyone can fit on mom's lap, although it may also be a sign of affection. Weaning. If a parent expresses a need to wean, it's important to explore their reasons. Some families believe that weaning may increase a child's independence or help the child to sleep more at night, which may not be achieved through weaning. Gradual weaning works best for both parent and baby. It reduces the risk of severe breast pain and mastitis. In several texts on nursing a toddler, the first suggestion is don't offer the breast and don't refuse the child's request to nurse. Eliminate a feeding every 2 to 4 days, preferably not back-to-back feedings. Continue as both the parent and child accommodate to the new routine. The parent can hand express for comfort as needed. And it's helpful also to change the daily routines for the child so that alternatives to nursing are offered and explored. Other foods or drinks can be offered as well, but just during those regular nursing sessions. And if the child requests, nurse the baby or the child and possibly shorten the amount of time that the child is actually at the breast or chest. Okay, great. Sekeita, I'm going to take a pause for just a moment. Are there any questions that we should address, or feel free to jump in here before I move on to milk supply?
Yeah, Angela, can you go over your mastitis slides just one more time? It appears that there are several questions about it. Understanding that you've already said the new protocol probably won't be on there, but if you could just give a little bit of clarification for the audience, that would be great.
So which aspect specifically?
So, yeah,
I would assume it's the...
I'll read the question. How about that?
Perfect.
It says, just making sure I understand, we use warm compresses, not cold for mastitis. Sorry, I am confused.
No, you're absolutely right. You see, warm and or heat can be utilized for mastitis, right? And the reason why there's a difference is because it depends on what the reason for the swelling. There's usually going to be some sort of swelling on the breast or chest whenever there is mastitis. And so if milk is flowing, it helps to keep that milk flowing, right? We want to keep the milk flowing as opposed to the stasis. Therefore, if the milk is flowing well, then you want to use heat on the chest or breast in order to keep the milk flowing. However, if there's swelling and yet there is less volume of milk being extracted, then you want to use the ice in order to reduce the swelling, possibly in the surrounding tissues, so that the milk can indeed flow. So you can use ice, you can use heat. There is no black and white. You only do something like this. And the same is true with breast massage. I know that the new protocol talks about breast massage and not to hyperlactate, not to continue to like pump the breast and like massage the breast. And notice how I'm doing that, massage the breast, right? You don't want to damage the surrounding tissue. It's very delicate. The breast tissue is very delicate. I believe, though, that many parents, when they hear, oh, I need to massage the breast, they're just like getting in there with their fingertips. And I've seen, parents who are bruised by such aggressive forms of massage. And so gentle massage, light massage, continuing to keep the milk flowing, those are the things that are things which are helpful. And it's important, I think, to note that there is no black and white. Does that help, Sekeita? Okay, good. Okay, great. Anything else about, I'm not surprised it's the mastitis. You're muted. Okay, good. So we've got it all. Okay,
Oh,
great.
yeah, all questions we've taken care of. I'm sorry, I didn't realize I was on mute. Yeah,
It's all good. Okay, great. Okay, good. So now I'll go ahead and move on to milk supply. And so this, just a quick picture, this is just to remind folks of the neuroendocrine reflex arc, to just sort of like jar your memory on the physiologic mechanism of lactation. Milk synthesis is a complex interplay of hypothalamic pituitary gonadal axis. Milk synthesis is related to the degree of breast fullness. Suckling or expression or other nipple stimulation stimulates prolactin secretion and the release of oxytocin. It is milk removal that enables milk secretion to continue. Now, this is a slide you may have seen in the Anatomy and Physiology, as well as the relactation exam reviews. According to Margaret Neville and Jane Morton, failed lactogenesis can be described as preglandular, glandular, or postglandular. An example of preglandular would be hormonal causes such as retained placenta or lack of pituitary prolactin. Glandular causes might be surgical procedures such as reduction, mammoplasty, or possibly insufficient mammary tissue. Postglandular would be any cause for ineffective or infrequent milk removal. This would include iatrogenic causes of lactation failure, and it is those which are impacted by policies and procedures in a hospital or by healthcare providers, which can have a negative impact on milk production. A parent's perception of milk supply in the early hours and days after birth could be included here. It is a common perception that a sleeping or quiet baby is a happy baby. Parents may misinterpret the baby's lack of settling post-feed as a sign that the baby isn't getting enough, and they may supplement. Parents may also interpret normal nighttime circadian rhythms as a sign that baby is hungry and assume a lack of milk. So now postglandular, those are any causes for ineffective or infrequent milk removal. Iatrogenic reasons for lactation failure include separation of the parent and the baby, pacifier use, and as mentioned in the previous slide, perceived insufficient milk by staff or family, which leads to supplementation. Interventions which require supplementation and milk supply, and when the milk supply is not stimulated, it needs, whenever that happens, that's when we can deal with sort of a postglandular reason for lactation failure and not producing enough milk. So just think about the supplementation scenario when the parent is told that they have to supplement their baby, and they may feel that breastfeeding has failed and they're worried about resuming breastfeeding. They don't trust it. Well-meaning healthcare providers may not encourage the resumption of breastfeeding if interventions are effective. Common scenarios include a baby who's diagnosed with hyperbilirubinemia in the early days after birth, and supplementation with breast milk substitutes is begun, or, for example, a 2-week-old baby who wasn't gaining effectively begins to gain with supplementation. In both cases, the parents, as I said, may be afraid to resume exclusive breastfeeding, and healthcare providers may not have, with all due respect, the time to create a care plan to help the baby to return to exclusive human milk feeding. Finally, there are some cultural beliefs that create a barrier to normal breastfeeding, such as colostrum, which is not enough or could be bad for the baby. Now, anomalies of the maternal breast tissue can include surgical interruptions in the breast, such as a breast biopsy, a reduction or a breast augmentation, and a chest tube as a preterm baby or thoracotomy prior to breast development. Mammary hypoplasia or insufficient glandular tissue is another reason, and breast asymmetry, including intramammary distance or the space between the two breasts. Maternal disease or parental disease, chronic illness such as hypo or hyperthyroidism, lupus, Parkinson's, diabetes, hypertension. Acute illness or birth-related complications include hemorrhage after birth, especially causing a sudden large drop in blood pressure and or requiring a blood transfusion. As a point of reference, 500 milliliters of blood loss is considered to be normal during birth. A hemorrhage, or more than that, may cause damage to the pituitary, ranging from mild insult to major infarction. Sheehan syndrome is a severe hemorrhage and drop in blood pressure that may result in necrosis of the anterior pituitary. Hormonal issues were referred to a few slides ago and are worth mentioning again. Irregular menses, infertility, obesity-related issues, PCOS. Weight loss surgery, specifically gastric bypass surgery, can impact the amount of nutrient absorption. Now, each one of these points could be reviewed in depth. If you have further questions about the specifics, please review your notes, lessons, or the literature. So other factors for delayed lactogenesis 2 include, and that means greater than 72 hours, premature delivery, insulin-dependent diabetes mellitus or gestational diabetes. Metabolic status or health refers to an interesting study from Nomson Rivers. They described 3 risk factors for delayed lactogenesis, such as higher BMI, increased maternal age, larger infant birth weight, as known correlates with carbohydrate intolerance and systemic inflammation. Now, let's also be aware that what may not have been mentioned in this study was fat-phobic bias and staff which are unaware of their bias. And we want to thank Kristen Cavuto for bringing this important concept to our attention. Delayed lactogenesis 2, so other risk factors include hypertension, high levels of stress to the mother and fetus during birth, cesarean birth, especially when it's urgent, prolonged stage 2 of labor, and that would be greater than 1 hour, augmentation of labor with intravenous oxytocin, forceps or vacuum delivery, the timing of the first breast stimulation following delivery, significant edema of the extremities, and endocrine disturbances. Complex interrelationships exist among the various factors that affect lactogenesis. Whether the delay of lactogenesis 2 is a maternal physiologic response due to delayed or ineffective suckling or a combination of factors has not yet been clearly established. Frequent, early, and effective chest feeding or breastfeeding appears to be the most important factor in establishing normal lactation. I would argue that skin-to-skin and milk expression in the first hours after birth are key factors to counter the possible risk factors that some people may present with. For those of you who work in a hospital setting, you can understand how that can be impeded with any of the above diagnoses. Okay, so let's see. Now we want to talk about the infant's role in milk production because it's not just one-sided. Chest feeding and breastfeeding and providing human milk for the baby is a two-sided factor. And so the infant can impact it. Any issues which affect sucking or suckling frequency may affect the initiation and calibration of milk production. The baby may not be capable of sufficient milk removal to initiate and maintain an adequate supply. Important factors include the gestational age, premature infants, of course. Remember that late preterm infants may not suckle well enough for adequate milk removal. The infant's oral and facial anatomy. Any tongue mobility restriction can impact not only the parental nipple discomfort, but may also affect the ability to remove milk. Palatal issues, obviously, including a partial or complete cleft of the hard or soft palate, but it could also include a high palate, a bubbled palate, or a channel palate. And airway issues such as laryngomalacia or tracheomalacia. Long term, the issues on the previous slide can impact the initiation and calibration of milk supply. The following can impact the maintenance of milk production, such as an infant with hypotonia or hypertonia, birth trauma pain, such as shoulder dystocia, or the use of vacuum or forceps, as seen on this slide, cardiac or respiratory issues. Long-term impact to milk production could be infant facial anomalies, the tongue or the palate, or sensory integration issues. And I believe you can see that on the top of the baby's head, and a very proud parent showing the wonderful skin to skin that they're doing in the hospital, that you can see sort of that inflammation of the infant's head. And there are actually several spots where they attempted to put an internal monitor into the baby's scalp in order to monitor the baby during the labor. As mentioned, prenatal education can reduce the use of supplementation in the early days by parents who believe the baby isn't, quote, getting enough. This is one of those solutions. During the hospital stay, frequent skin-to-skin contact can be very helpful. You really can't overdo safe skin-to-skin contact. Frequent colostrum or milk removal. Hand expression seems to work best in the early days. Now, a quick note, for parents who are pumping for their premature infant or who are having trouble extracting an appropriate amount, utilization of the other senses can help with the milk ejection reflex. There's a study that noted an improved milk output when the parent was looking at pictures of the baby and or listening to the baby's cry or coos, as well as smelling their t-shirt or blanket from the day before. Other education opportunities include explaining to parents the normal newborn circadian rhythms, visuals of the newborn stomach and nominal nutrition requirements in the early days, realistic expectations, alternative supplementation techniques if required, and of course, close follow-up. Okay, now we are going to move on to research questions. Sekeita, feel free to interrupt me if you'd like, or we will save those questions until the end. Okay, so research. Oh,
a little delayed. I do want to just ask this question.
Please.
Question about, could age also impact delayed lactogenesis? So the answer is, some of the literature says advanced maternal age. I know they call it something else. I'm choosing not to say that word.
Thank you.
But there is some indication that that could impact it, just due to sometimes, I don't want to say the deterioration, but for lack of better words, some of the glandular tissue starts to become a little bit more sparse. And so I just wanted to jump in and answer that. And go ahead, Angela, take it away.
Mm-hmm. Well, no, I was also going to say on that issue, you know, I also think it has to do with the hormonal response and the how well the hormones respond. And this also reminds me of something else, is that, you know, and I'll get to standard deviation in the next slide, but just as Sekeita said that, I immediately went back and I said to myself, I know a person who, and whenever I had a client who, and I actually had a client, first baby, they thought she was going into menopause at the age of 54 and they were pregnant. And she produced a fine milk supply at the age of 54. And therefore, you know, I'm sitting here thinking, well, wait a minute, there was that one case, but that may not necessarily be the answer that the IBLCE exam is looking for, and I'll explain it in just a sec. So when you're taking a look at variables in experimental study, the dependent variable is what the independent variable acted upon. For example, in a study of breast pumps, the volume of breast milk obtained when using several types of pumps were compared. The volume of milk is the dependent variable, and the type of pump is the independent variable. Now consider what we know about the effectiveness of pumping. It can be impacted by a number of factors. Therefore, confounding variables in this example might be the privacy of the place where the parent is pumping. That might also lower the amount that they're able to extract, or the time of day could be a confounding variable. Now, I just want to quickly review some frequently used terms. The standard deviation is a measure of how spread out the numbers are. So 68% will fall in the first standard deviation, 95% will fall into the first and second standard deviation, and 99.7% will fall into the first, second, and third standard deviation. So there's just going to be a few in that fourth standard deviation. Statistical significance is the level of certainty in the results of a study. If we want to be 99% confident of our results, we set the significant level at 0.01. If we want to be 95% confident of our results, we set the significance level at 0.05, which is most medical research. Therefore, if the p-value is equal to or less than 0.05, then that is the interpretation of our confidence level. Now, bias. There are a number of different types of bias, and it can influence research. For example, that piece of research which looked at the effectiveness of breast pumps, specifically the frequency of the number of cycles per minute. Now, you note that there's a university who supported the research is funded by a specific breast pump company. The researcher whose university receives funding from that pump company could be biased in their study design and/or the interpretation of the results. And informed consent. Subjects need to be informed about their rights, equipment, or medications used, procedures, confidentiality, and how to withdraw from the study at any time, as well as any rewards for participation. So here we have a list of all of the different concepts that you may fall into. Okay, so now we're going to go into question time. Now, this is not questions that you have for us. We are still going to answer those at the end. However, we want to ask you a few questions. And so now I will note that the poll doesn't allow for the picture or slide to show. So I will show the slide of the picture, and then Jill will take a look at then Jill will pop up the poll question. So she's going to give us a second, take a look at it, and then she's going to pop up the poll question, and then you can respond. So now, as I said before, we want to make sure that we are not thinking of the one-off, which said, oh, wait a minute, I knew of a case where, right? We want to go with that standard deviation, and that's the reason why I wanted to cover it today. So do be mindful that not only do you want to answer what is the most typically found, but you also want to answer like a lactation consultant. And so for those of you who may be other healthcare providers and or prescribing providers such as physicians or advanced practice nurses, you know, your response may be different than what a lactation consultant may respond to a specific question. And so I just want to be very mindful of that. Also, another note here is that for example, we have a couple of questions in the following slides on varicella zoster, and which is chickenpox. And during one of the previous exam preps, we reviewed the recommendations on that, and we found like 3 different resources. We found 3 different answers in the books that we had. And so what is someone to do? Remember, you want to choose the international resource. That is what you want to study. If there isn't an international resource or a clear-cut answer, understand the why. One may be able to assume that there will not be a question about it on the IBLCE exam if there are so many different types of questions. And so, and there's no clear-cut answer for how to proceed in a specific case. Okay, so give you a moment to read this. Physical breast presentation which may contribute to low milk supply is either significant inframammary fold, a breast cup size less than B, significant intramammary distance, or hypoplasia of the superior breast tissue. Okay, Jill, pop up the question. Okay, great. And so we threw this in there because we just want to check to see if you're familiar with some of that medical terminology which is required before you sit for the exam. Okay, so we're going to go ahead. This is really interesting. Sekeita, are you watching this? Or can you see this? I don't know if you're watching or not. Okay, let's go ahead and close the poll. So what's interesting is that we have a 50-50 split here. That half of you said a significant intramammary distance, and half of you said hypoplasia of the superior breast tissue. And so the answer is D, hypoplasia of the superior breast tissue. So significant distance between the breast is intramammary distance, which may be associated with hypoplasia. Cup size doesn't matter. Hypoplasia of the upper breast tissue does not indicate insufficient glandular tissue. Hypoplasia of the lower, medial, and lateral quadrants do. Wait a minute. I just said the wrong answer, didn't I? Silly me. You're laughing. You're muted. I'm glad I don't hear that laughter, but go ahead, Sekeita. The answer is C. My goodness, the answer is not D, the answer is C. Okay, good. You see, I'm reading it and I'm like, wait a second, what? No, that's wrong. Okay, so just want to give you the answer that the correct answer is significant intramammary distance, that distance between the two breasts. Okay, great. Sorry, Sekeita. All right, so going on to the next question. Here we go. A postglandular reason for insufficient milk production is early introduction of hand expression, pacifier use, retained placenta, or previous breast biopsy with periareolar incision. Okay, go ahead, Jill. Okay, give you just another minute or so, or I'm sorry, another few seconds. So postglandular reason. Okay, go ahead and close it. Yep, majority of you got this one right. Pacifier use. So it's postglandular reason for insufficient milk production. So very good. Okay, going to the next one. Oh, did you have something to say, Sekeita? Sorry.
Yeah, I just noticed that 50% got it right? There's a wide variance of who got that. So I would say overall, maybe revisit what postglandular means. And yeah.
And that's Margaret Neville and Jane Morton. It's their research that I was referencing. Okay. While reviewing your postpartum patient's chart, you see they receive Pitocin, or synthetic oxytocin, and Methergin. Oh, methylogovine maleate. I apologize that I didn't say that correctly. After vaginal delivery. You know this patient most likely experienced normal blood loss, experienced excessive blood loss, gave birth to multiples, or will not be able to breastfeed. Okay, Jill, go ahead. While reviewing your postpartum patient's chart, you see they receive Pitocin and Methergin after a vaginal delivery. So what is most likely? Okay, this one's a little easier for folks. I'm glad. After the last two. Okay, great, Jill, go ahead. So yes, the response is correct. 86% of you got experienced excessive blood loss. So indeed, especially with the two medications that are utilized there, that's the thing that should get your attention, and also what to do. So I'm glad none of you said, or no, a couple of you did say that. Okay, never mind. Moving on. Lila lactation consultant did a study at their hospital where she surveyed the parents' duration of breastfeeding. She found the range was 1 week to 18 months with a mean of 8 months. What type of research is this? Quantitative, qualitative, historical, or epidemiological? Okay, go ahead, Jill. Lactation consultant did a study in their hospital where they surveyed the parents' duration of breastfeeding. They found the range was 1 week to 18 months with a mean of 8 months. So what type of research is this? Well, this is good. Another couple seconds. Okay, good. Go ahead, Jill. So most of you got this right. The answer is quantitative. It's based on data. It's not experimental. and it does not attempt to determine causality. So here's just a brief description of the difference between qualitative and quantitative research. Okay, great. Moving on to the next one. Lilo Lactation Consultant is a busy person, did another study at their hospital where they surveyed parents about their satisfaction with breastfeeding and what problems they encountered. What type of research is this? Quantitative, qualitative, historical, or epidemiological? Go ahead, Jill. So now, of course, some of you have this. Okay, good. Let's go ahead and close the poll. So some of you got the fact that, the other question was quantitative, therefore this one may be qualitative, and you're right. IBLCE doesn't provide such clues like that, just FYI. And so indeed, this would be considered to be qualitative research, exploring reality based on perceptions, consider multiple perspectives, and no attempt at causality. Okay, great. So let's move on to the next. Iron levels are low in breast milk. What instruction should parents be given? A, supplement with iron drops until the baby begins solid foods fortified with iron. B, breastfeed, no supplementation needed. C, breastfeed and supplement at 6 months with iron fortified foods. D, increase the amount of iron in the parent's diet to increase the amount of iron in the breast milk. Okay, go. So this is good. The results coming in, another few seconds. Okay, great. So the results are, the majority of you got it correct, which is breastfeed and supplement at 6 months with iron fortified foods. That is correct. Just one note is that additional intake by the mother will not increase iron levels in breast milk, even if the parent is anemic. Iron supplements taken by the parent have been seen clinically to produce some constipation in the baby. And anemia in the nursing mother has been associated with poor milk supply, however. So that's something which is important to note. And so majority of you did get it correct. However, be mindful of that fact is that you want to wait on the supplementation until 6 months with foods. Okay, this question, vitamin D levels are low in breast milk. What should we do about that? A, supplement baby with vitamin D until solids are started. B, breastfeed, no supplementation needed. C, breastfeed and spend a half hour a day in the sun. D, baby should be supplemented with 400 IUs of vitamin D daily. Okay, go. Okay, there we go. So the correct answer is D, baby should be supplemented with 400 IUs of vitamin D daily. And that is something which the guidance was written a couple of years ago. And what was interesting about this is that it is important for babies to be supplemented, that the World Health Organization, this is their recommendation, and I'll quote, there appears to be consistency across the world that newborn infants are at an elevated risk of vitamin D deficiency, and that a vitamin D supplement to exclusive breastfeeding is highly recommended in the primary prevention of vitamin D deficiency and rickets. And so I do know that in some of the literature it talks about to provide human milk and spend a half hour a day outdoors, but you can't determine what latitude that's at. because the sun in different areas is different. Therefore, we can't make universal public health recommendations based on that. Also, there is a risk of babies getting sunburned by doing something like that. To say that no supplementation is necessary, the World Health Organization does think that it's enough of an issue where supplemented with the 400 IUs of vitamin D daily is what's recommended. Okay, great. Next one. So how old is this baby? So the question is whether or not the baby is about 2 weeks old, 4 months old, 2 months old, or 8 months old. Now this one is a little tricky. Oh, and this will also give me a chance to say that yes, I do know that the World Health Organization, or excuse me, the Centers for Disease Control and Prevention has changed their developmental milestones. And Julie, the wonderful customer support person on the phone today, has noticed that the changes were not so substantive. Meaning they sort of like rearranged things and they made things just a little bit delayed. And so we may replace this question during the next time we present this content. So here we go. Okay, go ahead and close it and I'll show the picture again. So some of the hints that you want is that the baby has a social smile. The baby can lift head by about 45 degrees. Baby can hold head up for a few seconds. And they are visually searching to locate the familiar face or sound. Now notice that the baby is able to push themselves up a little bit. However, it's not for that long. Hold on 1 second. 2 weeks, 4 months, 2 months. Ah, okay, good. Yeah. So indeed, the majority of you got this correct, which is 4 months. But again, it's very challenging. You know, a 2-month-old baby is not going to be able to sustain that position for very long. Therefore, and a 4-month-old should be able to do more than just lift their head up. And so this would be closer to a 2-month, but unless you're there with the baby and you can actually see whether or not the baby is able to sustain that position for an extended period of time, that may be something which is a little challenging or tricky. Okay, going to the next question. Which of the following viruses is most likely to be transmitted to the infant through breast milk from an infected parent? Hepatitis C, herpes simplex virus, varicella zoster virus, cytomegalovirus. Okay, go. Which of the following is most likely to be transmitted to the infant through breast milk from an infected parent? Give it another few seconds here. Wait till about 25 seconds, Jill. This one's a little tougher. Okay, go ahead. So this may be one that people want to study. So it seems the majority of folks chose hepatitis C, and actually the correct answer is cytomegalovirus. And so CMV transmission from parent to infant occurs in about 60 to 70% of breastfeeding dyads, whereas the breastfeeding parent is infected with CMV. However, healthy infants who acquire the infection in this manner are almost always asymptomatic, and chest feeding or breastfeeding should be encouraged. Premature infants and immunosuppressed infants are at higher risk of complications from CMV infection, and there is debate about whether these infants should receive CMV positive breast milk. Herpes simplex virus and hepatitis C are unlikely to be transmitted via breast milk. The varicella zoster virus, which causes chickenpox and zoster. Infected parents should be encouraged to breastfeed. The infant should be protected from direct contact with skin lesions. Sekeita, I saw you pop up. Did I get it right?
Yeah, I popped up because I just wanted to leave the audience with this tip. There are very few contraindications to providing breastfeeding in human milk. I would recommend that you look up and know those contraindications. That's just a tip.
Right, yes.
Because it might not be this type of question, same question, but it will be a variance of. And so cytomegalovirus is one of those things where it's contraindicated. So that's the word I want you to think about.
And I also note that a majority of the participants, thanks for checking in and letting us know where you were listening today. A majority of the people who are currently on the call actually are in the United States, where CMV is not as common as in other parts of the world. So that could be a reason why the majority picked hepatitis C. Okay, great. Thanks, Sekeita. All right, moving to the next question. Tyler is a vegan. What would you suggest to ensure adequate nutrition for parent and baby? Proteins from beans and rice, minerals such as magnesium and selenium from grains, folate from dark green leafy vegetables, or B12 from fortified foods or supplements. Okay, great. So for the vegan parent, go ahead, Jill. Thank you. Protein, minerals such as magnesium and selenium, folate, or B12 from fortified foods. Okay, good. It seems like a majority of folks are getting this one, which is great. Now remember that these questions are not IBLCE questions. These are Angela questions. Therefore, they will not necessarily be on the exam, nor will they be, so don't feel either good or bad if you're having a tough time with some of these. Okay, good. Go ahead, Jill. So 80% of you got this correct, which is B12 from fortified foods or supplements. So vegan diets include no animal products, which are the only dietary source of vitamin B12. To avoid a B12 deficiency, vegan nursing parents and those who consume very little animal protein may need to take steps to make sure they receive vitamin B12, either from foods enriched with B12 or by taking regular B12 supplements. Is that good, Sekeita? Anything else? No, you're good? Okay, cool. All right, let's move on to the next one. So the primary reason for supplying breast milk for premature infants is to A, improve bonding between the breast chest feeding parent and baby, B, assure continued breastfeeding chest feeding after discharge, C, prevent necrotizing enterocolitis, or D, improve neurologic outcomes. Okay, everybody. Well, in this one, I'm thinking is a little bit, it's interesting because it's the primary reason. So that's something else you want to note. What is the primary reason for supplying human milk for premature infants? Okay, great. Go ahead and close the poll. A majority of you said to prevent necrotizing enterocolitis, and so that is correct. Indeed, human milk does improve neurologic outcomes. It does increase bonding. It does assure continued breast and chest feeding after discharge. However, the primary reason is to prevent NEC. Okay, great. Moving on to the next one. Risks of skin-to-skin care in newborn infants include respiratory instability, sudden unexpected postnatal collapse, hypothermia, sudden unexpected infant death. Okay, go. So what are the risks of skin-to-skin care for newborns? Give it another couple of seconds, Jill. Okay, great. So indeed, the answer is B, sudden unexpected postnatal collapse. And so it is important, that is something which is important. Sekeita, I know you just updated a lecture on skin to skin and continuity of care. Do you have anything to add to sudden unexpected postnatal collapse?
The only thing I would add to it is just to know what that means. Like, I think that skin to skin is safe. However, there's a safe way of providing skin to skin care, and learn what that looks like, what does safety look like. So because, no one wants to think that skin to skin has any risk, right? But know it.
Right. And so the second answer that people chose was D, sudden unexpected infant death, but that's something which actually has an unknown cause. And yet the sudden SUPC is very clear parameters. It's usually within the first 7 days after birth. Correct me if I'm wrong. Usually within the first 7 days after birth, baby has an APGAR greater than 8, and there doesn't seem to be any other reason why. And so do be mindful of that and the difference between those two when you are considering skin to skin. Okay.
Yeah.
And the risks to skin.
You just made me think of something about
Please.
the time to expect the unexpected collapse. 7 day. I gotta look that up because I don't know, but I thought it was roughly associated after birth in those first few days. But that brings to a point that, yeah, I should know this, right?
It should be, well, so that's a good question, right? I mean, is it 7 days or is it something which is a bit earlier? I know
Yeah.
Julie is there. Actually, one of us can look this up while the other one's talking. So
I think I'm gonna look it up because I
or
should know.
Julie's gonna look it up. Okay, so we'll have this answer for you. So I apologize for not having it right off the top of my head. Okay. Questions. This technique is useful for all infants except premature infants, Down syndrome infants, neurologic impairment, or infants with type 3 ankyloglossia. Okay. So when is this technique not helpful? Now, this is a negative stem. Hopefully you won't have too many of those on the exam. But it's important for you to know what position this baby is in and how the parent is supporting the mammary tissue. And so those are a couple of clues. And I think most of you are getting this correctly. Okay, go ahead, Jill. So the answer is D. And so what is this hold? This is known as a straddle hold. And this is the dancer hand position. And so that's what the position is that the parent is utilizing in order to support the infant's cheeks. And so the type 3 ankyloglossia, it's helpful in premature infants. It's helpful in infants with Down syndrome. It's helpful with infants with neurologic impairment, but not necessarily type 3 ankyloglossia. So also be mindful of the fact that when talking about tethered oral tissues, while that may be a really popular topic in the lactation world, it may not be a popular topic on the IBLCE exam. And so understand that there's so much to cover, and pathology and infant pathology is only one small part of the exam. So if you're studying 38 different resources on ankyloglossia, maybe you might want to stand down a little bit. Also, this type thing where we're talking about what type it is. So lactation support providers do not diagnose what type it is. Also be mindful that lactation consultants and, as I believe it's dentists, categorize them backwards, different from each other. And so 1, 2, 3, 4 is the lactation consultants moving from the anterior to the posterior part of the mouth, but a dentist is going to say 4, 3, 2, 1, again from the anterior to the posterior part of the mouth. Therefore, just be aware of that fact. Okay, moving on. Last question. The World Health Organization guidelines for preparing powdered infant formula recommend A, boil the water and teats for 20 minutes, a rolling boil. B, boil the water used for mixing for 20 minutes, a rolling boil. C, mix the measured amount of powdered formula and hot water meaning 70 degrees centigrade or 158 degrees Fahrenheit. Or D, prepared stored bottles in refrigeration for up to 72 hours. So which one of these guidelines are utilized by the World Health Organization guideline for preparing powdered infant formula? So do you boil the water in teats for 20 minutes? You boil the water for mixing the formula for 20 minutes? Do you mix the measured amount of formula in hot water, or can you store prepared bottles in refrigeration for up to 72 hours? Okay, great. So the world has changed since the formula shortage and the crisis that occurred in the United States with the manufacturing of powdered infant formula. The correct answer is C. Mix the measured amount of powdered formula and hot water. So that's something which is important. While you do need to wash and boil the bottles and teats as well as the water, it's the 20 minutes that's incorrect. And so you do not need to boil either one of those products for that length of time. And so that's why those two answers are correct. And storing prepared bottles in the refrigerator for up to 72 hours, the answer is actually 24 hours. So that's the reason why that is an incorrect answer. So thank you very much. I hope y'all feel a little bit better here. And now we're going to move on to Sekeita, who's going to talk about exam day survival guide. Sekeita.
Yeah, thank you, Angela. Before I begin, I do want to just circle back to sudden unexpected postnatal collapse. And I'm just going to read the excerpt about, the greatest risk. Really, it is that skin to skin, that safe skin to skin time, the first few hours after birth. And it's usually, how do I say, a person's potentially not really supervising that safe skin to skin, not really paying attention to the family. So what I'm reading from is from Breastfeeding Management of the Clinician. Let's see, this is the 5th edition using the evidence. And this sentence states, the first 2 hours of life are the hours of greatest risk, coinciding with the time frame when breastfeeding and uninterrupted skin-to-skin contact between women and newborns is encouraged. And so I hope that clears up that part of the question. All right, so recognizing that I am supposed to do about 12 slides in about 3 minutes, this is supposed to be a 90-minute section. I talk fast anyway, but I really encourage you to stay on. Some of this information that I have is extremely important for you as the person taking the exam. So, survival guide, just put your hands down for a minute, take a cleansing breath. We've gone over a whole bunch of things, but give yourself a hand. You have made it in it's almost 30 days or a little over 30 days. You will be in somewhere taking the exam. Preparing for this has required dedication, passion, and endurance. And simply when you get to the exam day, just remember that, bottle that up and take that either to your computer, because recognizing that some folks will be taking the exam at home via live proctoring, and others may be taking it at an actual building, because this is an international exam, and as the pandemic guidelines fluctuates throughout the different areas, this continues to be a fluid type of situation. So just give yourselves a hand, and I'm going to try to give you this crash course in a couple minutes. So let's take off. See if I can do it. All right. Again, staying connected to your passion, really celebrate the dedication and be proud of your endurance. And this is a part of that preparation. Know that if you're just starting to get prepared for real, that you still have a great amount of time to really be successful on this exam. All right, I already talked about breathing deeply. When I say breathe deep, I usually mean in for 4 and out for 4. That's the recovering labor and delivery nurse in me. And it looks like slow breaths, like in for 4 and you're counting to 4 and you're letting it out. That's a breathe deeply. Sometimes that does help to calm our nerves during exams. So I don't say that lightly. It also helps to calm during anxiety. There's a lot of folks doing breath work, and really and truly breath work does work. All right, so before the exam, it's extremely important. We're going to drop a couple of links into the question area, the chat area. It's extremely important that you look at these links, that you read them, because there's so much important information. Know that if you are doing live proctoring, there's going to be 3 online agents that will be assisting you to set up. There's going to be your readiness agent, your security agent, and your remote proctor. The readiness agent is the person that's going to assist you to set up and conduct your ID checks. So understand what you need. You need your photo ID for the purposes at the beginning of the examination. There will also be an environmental check. So which means you will have to take your laptop or computer or webcam and scan the entire room. So those are the types of things to expect. Also know when breaks are. You know, you have to have, unless you've made other arrangements, breaks are allowed between that first part and second part of the exam. However, you still have to, before you just get up, you still have to communicate with the proctor that, okay, I am going to go go to the restroom or whatever that thing may be. But you really need to know. So if you read nothing else, don't skim it, read it, because we skim a lot of things and a lot of folks can get immediately terminated and kicked out of their exam for things that could be preventable. So there are computer system requirements. If you are taking the exam at home, understand the requirements, know what to do if you have technical difficulties. These are things to kind of research prior to, because sometimes we do have spotty internet coverage. Sometimes we don't have access to plug in into a hardwire or Ethernet cable. Those are things that really we should have an understanding. But the first true thing we have to have is the appropriate equipment to be able to take the exam. So you need operating systems of Windows 8.1 or higher, or if you got a Mac, 10.13 or higher. And know that ProProctor does not support Linux products. And I'm going to tell you this because we've been doing this for a couple years now, I think, Angela. And when I always go back to look at Premature's requirements, and this one was new. ProProctor does not support Linux products. And I said, what's a Linux product? I don't know, but I'm sure that someone found out probably near when they were supposed to take the exam. So have the most current version of your Google Chrome current, because that's the software that the Prometrics system works off of, and make sure that you have working audio speakers and your microphone is required. Your internet speed should be 1.0 megabytes per second or greater. And again, the link is on this slide. Please feel free to look those things up so that you know that you are ready and your system is good to go. Other things that I do want to talk about before moving on is that your webcam will need to be movable. A webcam and a laptop is acceptable, again, as long as you're able to move the laptop to show the entire room. Your power source, a laptop PC plugged directly into a power source. It cannot be attached to a docking station. And this again comes from their website. Okay, I think that's it for that. I'm trying to get you all out of here. It's 3:33. I'm past 3 minutes past. All right, for those that are going into the testing centers and sites, please make sure that please know that you are required to wear masks or face coverings for the entirety of the time that you're at the test center, as well as complying with any additional local requirements in place at the time of testing. So it would be a good idea to really touch base 2 days before the exam to call and say, hey, are there any additional requirements? So know that. Before the exam, have a plan. Plan to be alone. There can be no pets or no people. So for example, you leave the door open to your office or your room and the cat comes in. That is a means for disqualification or termination. You also want to be where the internet is the strongest, where there is good lighting, and anyone else that's in the home that has access to the internet, make sure they just don't stream, no movies, no YouTubes, no games, none of that. If you have the opportunity to hardwire, I mentioned this before, hardwire your laptop or your computer into a Ethernet cable, that is preferable, but just make sure you have complete quiet time. I think that's it for that, yeah. All right. Some of the things that are helpful for some students are to create a playlist to boost your confidence. Sometimes, some people are just not great test takers. It doesn't mean they don't have the knowledge. It just means sometimes that they have difficulty translating that knowledge onto standardized tests. So write yourself words of encouragement, put it around your house. It makes a great deal. Put it on your refrigerator. Exam in 3 days. You got this. However you want to express yourself, but try to do those things so that when you go in, at least some of that nervous energy you've already poured into yourself, so that that nervous energy is not so nerve-wracking. When I say take your exam temperature, the only thing I'm asking is to really think about what has worked for you in the past. Think about when you've been successful on certain tests, and think about when you haven't been so successful. What was the difference between the two? And you want to channel. What are you doing? Are you doing what you did when you were successful in the past, or not so much? And then just make the adjustments. The night before the exam, find your inner calm. And yes, I still do have a home phone, so I'm sorry that I just did that. Find your inner calm. Really, the night before the exam, you want to refrain from like crash studying, because that can actually increase the anxiety level of going into a test. So make sure that you just really just say, trust in your process, trust in your preparation, and just kind of put all the materials away and just find your inner calm. The day of the exam, eat something that your body is used to. Please don't take this day to be like, well, I'm going to treat myself. I made it to the exam. I'm going to have this exotic breakfast or exotic lunch. Nope, don't want to do that. You don't want to have an upset stomach. Wear comfortable clothing if you are actually going into a testing center. And sometimes that may mean, wearing layers depending on how cold it is there. Again, do your best. You're ready if you take the preparation that we've kind of given and laid out for you. There's a total of 175 questions. There are going to be 2 parts. They're divided into the questions are usually multiple choice, as we just showed you. Sometimes there's images. On the images, the one thing I'm going to say is don't try to read too much into the image. You want to look at the question and then look at the image and really figure out what the stem of the question is asking you. There is a 4-hour duration of the test. If you English is not your primary language, there's 30 extra minutes allotted. You have to make sure that you have already talked with IBLCE to make sure that you will have that extra time. Each question has only one correct answer, and there's no penalty for the wrong answer. So it's to your advantage to answer all of the questions. The way the questions are formatted is, if you are having issues and you just don't know about that question, you answer it and you flag it. If you have time to go back, you flag the questions that you're able to go back to, but you do want to answer it. Don't skip any questions. Read each question slowly. The reason why I said read those websites word for word, because that will get you into the motion where you are actually not skimming but reading. Think about what is the first thing you would do. Eliminate the obvious wrong answers. Angela had a question and it said, what is the primary? You want to key into those types of words. Or what is the best answer? What is the first thing you would do? And when I say first thing, sometimes you would do both things, but what is the first thing? What is the priority? And so that's the gist of what test questions are like and what you can expect. All right. Work at a comfortable thought. I think we've already, I think I jumped ahead and said some of this stuff, so we can go to the next slide, because this last slide is extremely important and I don't want to keep people more than they need to. So immediate termination or dismissal. Now, I wanted to come to this slide because I have about 6 bullet points on this slide. I want to tell you that there's about 20 bullet points. This is not an all-inclusive list, but these were the top 6. So you must not leave the examination workspace for anything. The only time you're permitted for a break is between part 1 and part 2. Candidates must alert the proctor before moving away the webcam during the break and after finalizing the examination. So you have to get the all clear. Leaving the view of the webcam without acknowledgement from the proctor, including during your scheduled break, will result in an immediate dismissal from your examination. There's no third party or person that may be present in the room. And remember, I gave the example of the cat. That's cat, dogs, people, anything, anybody. There can be nothing that comes in the room. Turning off the light or computer audio, moving from your original testing location, or speaking to or receiving aid from other individuals is strictly prohibited. All right, so after saying all that, I know when you're done, you are done. Don't second guess yourself. Sometimes your first answer is the best answer. Sometimes it's easy to go back and say, oh, I think I usually go with your gut. So this last slide is to say there are certain ways that we say that we're done. Some people are like, just like, Bly's done, or yep, that check mark, on to the next. Some people are a little determined, like the little guy in the green. He's like, yeah. And the person that's looking at that fire is like, okay, this was more than a notion, but it's done. I don't have any energy left. So it is possible. This is possible. It always seems impossible until you are done. So best wishes, good luck. Remember your why, remember your passion while you're waiting for results. Please don't just keep going and going and going. Take some time to remind yourself that you did the best. And in the meantime, while you're waiting on your results, stay connected with your professional community. Keep learning, developing your plan on how you're going to practice. What are your next steps? Because waiting, it does sometimes seem like it takes a long time, but you want to be proactive and still looking forward to being able to be out there using those skills once you get your results back. So best wishes. Angela, were there any final things? Because I tried to go really, really fast.
You did go quickly. Such valuable information, Sekeita. Thank you so much. And I think we have so many people on the call because still here because you're just interested in hearing as much as possible to be prepared. So there were a couple of questions about the powdered infant formula question and whether or not the water should be cooled prior to body temperature prior to adding it to the powder. And the answer is no. You do not want the water to cool, and the reason that much. And the reason why, it's because when it's at that high of a temperature, that is when it kills any contaminants which could be in the powder. Therefore, any of the bacteria as well. So that's why it's important to not allow the water to cool for more than, let's say, 20 minutes. And I believe that's actually in the WHO guideline is within 20 minutes or within 30 minutes that you do need to add the powder to the hot water. And so another question that came up has to do with, give me one second.
I think the WHO actually in their document talks a little bit about the rationale for that, is that it takes 100, the reason why they're specific is 158 degrees Fahrenheit or 70 degrees Celsius is what kills Chronobacter. It has to be that hot to kill
Exactly.
Chronobacter.
Yes, yes, that's very true. And in some parts of the world, that's not conveyed. And so it's important, even if you are in a country where they have instructions on how to mix powdered formula on the side of the can, if it does not have that recommendation, it is incorrect. A lot of people are asking about their English is not their primary language, or the language that they're sitting the exam is not their primary language, or they've got some sort of learning issue and they are looking for more time on the exam. You must reach out to IBLCE prior to sitting the exam. It's not something that you can just walk in and say, oh, I get an extra 30 minutes, because you need to make sure that that is approved by IBLCE prior to sitting the exam. Let's see, what else? There's a lot of questions about the score. And so there's no penalty for a wrong answer. The answers are, the questions are weighted equally. Therefore, it's, you know, it's either a yes or no, it's a black or white. And so either you're going to get the points or you're not going to get the points. And so that's something which is important, which is why Sekeita said not to skip any questions, because you will get a penalty for that. If you're looking at a question and you have zero idea what the answer is, you have a 25% chance of getting it right. So guess, guess on those things. Someone is asking, what is the passing number of questions or percentage required to pass the exam? IBLCE actually sets that each exam cycle. And there's a complex reason why, but it has to do with the psychometric practices by which they follow. And to provide you with just a little bit of reassurance, more than 82%, actually, Sekeita, you and I were reviewing the data the other day from 2019. It was like more like 84 or 85% of people, first-time candidates, pass this exam. Therefore, the chances of y'all passing this exam are super high. So allow that to give you just a scope, just a little bit of rest assured that chances are likely, you've done all this preparation, chances are likely you're going to pass the exam. Let's see. Someone asked earlier, and I forgot the actual question, but someone said, what if breasts appear to be quote unquote normal and yet the parent doesn't have enough milk? And that's absolutely possible. I mean, there could be some sort of postglandular or preglandular reason why the breasts would appear to be normal and yet the parent isn't producing enough milk. Let's see. What score should you aim for or feels comfortable with the practice test on your website? So there, I think it has to do with what your comfort level is. Some people won't be happy unless they get a perfect score. Some people won't be happy unless they, so in other words, setting some sort of standard may not be very helpful to you. And I think that there's not one exam which is going to say to you, oh, I did really well on this exam, therefore I'm going to pass the exam. Know the areas where you need additional support. Know those areas where you've got it. At this stage of the game, don't focus on those areas which you've got. For example, if you work in a hospital, let's say you're a labor and delivery nurse and you work in a hospital and you know those first 3 days, absolutely, study the nursing toddlers. Study the older babies, study maybe a bit more of the medications that may be utilized outside of that hospital setting. So find something that you're comfortable with. If you're a peer supporter working in the community and you have no clue what happens in a NICU, that's where you want to study. So just, use those tests as a way to help you to know where to study, where to focus your efforts in these last few weeks before the exam. Yeah. Anything else you see there?
No, but you said study. I just want to refer folks, if they haven't seen the Creating a Study Plan, the other live that we do, Angela, to help folks really create a study plan that's individualized for them. We all have different study habits, study methods, some of us like to study in groups. I would say do that. Sometimes it's helpful to at least have that group study at least one time. You get to feed off of one another. You get to really understand maybe some of the areas that you have limitations in. Someone else has, a wealth of knowledge to be able to give to you. That is the challenge always.
Yep, I agree with that. I'm just answering a couple of questions here. Someone is asking, let's see. So you can access the study plan on our YouTube page. I think it's also on our website. Julie will correct me if I'm wrong. She'll type it into the chat. Let's see here, sorry. Somebody's asking about bathroom breaks, and is 4 hours enough? 4 hours is enough. So there's actually standards by which exam organizations, there's actually a calculation as to how long each question should take. And IBLCE does understand what the data shows as far as how long each person is going to spend on each question. And therefore, the 4 hours that they provide for a strong majority of folks, 4 hours is more than enough time. So I hope that helps. Anything else in there, Sekeita, or should we wrap this up? Somebody asks how many people are taking the exam this September. We don't know. A lot.
This is an international
I don't mean
exam.
to be, yeah, I don't mean to be flip about it, but I mean, we're talking, it could be probably a couple thousand people.
Yeah. I really just want to caution you to really think about some of the topic areas that we've talked about, and if there are any challenges that you had during this particular session, I would say those are your focal areas. Those are the areas to really brush up on. And really, if you have not dedicated and set out around times that you're going to be consistent in studying, please do so. It's strange to me, and I'm going to say this because I am a nurse, that a lot of times I've had nurses say, oh, I don't need to really, I know this. And I can tell you, I've heard of physicians also, I know this. This is a test related to lactation management, clinical management of lactation, not clinical management of just the baby by him or herself, not just management of that birthing parent or person, right? It is the whole picture of. And so I just want to caution you to think about that aspect. Think about the fact that, you know, even Angela, you said something that made me laugh about the formula. You said some people in other countries, and I'm like, there are a lot of people in this country that don't know how to prepare infant formula. No, I'm so serious.
No, you're absolutely right. No.
And so I can't stress enough World Health Organization. I think Angela does such a great job in always letting you know World Health Organization, because their guidelines, because this is an international exam. So in that, I just want to leave with this final question. It says, can I please ask what the answer to the final question? I missed the answer, the formula one. That question was flagged. And I think I was just talking about that, but the answer is that the water needs to get to 70 degrees Celsius, 158 Fahrenheit. And then you can add it to the formula.
That's it. And actually, if we all practice this, then there would be a lot less morbidity and mortality in all countries if we follow these guidelines. And so there we go. Good. Well, thanks you, everybody. Thank you all so much for joining us, today, this evening, this afternoon, and watching this on YouTube afterwards. You can watch this as many times as you need to. Thank you all, and really good luck on the exam.
Yes, good luck, and thanks for hanging in there with us. Angela, next time we just slating it for 2 hours, okay? Because it's 90 minutes.
Exactly. Yes. No, we need to. That's for sure. So, and thank you all for your questions. They were really, they really did help us to move this along and to share the knowledge. So thank you all very much.
And you all help us to get knowledge. Like, I knew that SUPS question, but it was like, wait a minute, I need to look that up again. It's been a minute since I worked in a hospital, So yeah, thank you for those questions, because it keeps us sharp. So enjoy the rest of your day. Thank you for hanging out with us, and good luck and best wishes.
Bye, everybody.